Good afternoon, everyone, and welcome to this event as part of the ESRC's Festival of Social Science. Thank you very much for coming. My name is Ben Zaranko. I'm an economist at the IFS, and it's my great pleasure today to welcome three speakers who are going to talk to us about the challenges facing health and social care during and indeed after COVID. We'll first of all be joined by my colleague Max Warner of the IFS, who'll talk about some of the immediate challenges facing the health service during the pandemic, heading into what could be a particularly difficult winter. We'll then be joined by Stephen Rocks of the Health Foundation, who will talk about some of their work modelling some of the pressures facing the NHS that predated the pandemic, and in particular some of the underlying challenges associated with an ageing population. And then finally, we'll have Sally Warren, who is Director of Policy at the King's Fund, talk to us about some of the very topical issues in and around social care. The plans for that to take all in all around half an hour, so we should have plenty of time for questions. If you'd like to ask a question, you should all have been sent a link to the Slido page, or it should be available on the page wherever you happen to be watching this. So please do pipe up with any questions you have. You can also vote for other people's questions that you like the look of, and hopefully we'll have a wonderful discussion. So without further ado, I'll hand over to Max, and we'll go through those sessions in turn, and we'll be back for Q&A.
Thank you, Ben. So as Ben said, I'm going to spend the next 10 minutes or so talking about ongoing COVID pressures on the NHS. And clearly the NHS faces many COVID-related pressures. And so we found in our work, it's really useful to distinguish between direct and indirect effects. So direct effects are pressures coming directly from the virus itself, such as treating COVID patients, delivering vaccinations, and infection control measures. Indirect effects are those coming indirectly, so they're coming from our response to the pandemic or other changes. And as we're going to see, indirect pressures are large too, and they'll likely last much longer. So even if COVID disappeared tomorrow and these direct pressures disappeared, the indirect pressures, because they've been accumulated over the course of the pandemic, would remain. And these include things like catching up on missed activity, mental health changes, and workforce challenges. And this is on top of pre-existing long-run pressures that Stephen is going to talk about more in his presentation. So the most direct pressure on hospitals is that they have to treat COVID patients. So this chart here shows the number of COVID patients in English hospitals. Throughout, because health has devolved, I'm going to look at English data, but these issues apply to all four nations of the UK. So you can see quite clearly the rise in both the first and the second wave of the number of COVID patients in hospital. And if you look to the right, you can see that right now there are still about 6,000 COVID patients in hospital. Now, this is far less than the first and the second wave, but given that England has about 100,000 hospital beds, that still represents about 6% of hospital beds right now having COVID patients in them. This would likely actually be much higher had it not been for the success of the vaccination programme. That has clearly reduced pressure on the NHS overall, but nonetheless, the NHS itself still needs to deliver vaccines. So this chart here shows the number of COVID-19 vaccine doses delivered per day in England. You can see it fell in the summer as most people had already received their first and second dose, but then has risen in the autumn, mainly due to the booster jab programme. And this is happening on top of the standard winter flu vaccination programme, and therefore taking up a lot of resources in GPs and primary care more broadly. But actually, although COVID vaccinations and treating COVID patients are very visible, emotive signs of the pandemic, infection control measures are also particularly costly. These include things like keeping COVID and non-COVID patients separate in hospital. Staff need to take time changing PPE between treating patients. There's reduced capacity, even for non-COVID treatment, as patients still need to be kept apart. And certain treatments require additional measures on top of this. So as well as all the effort and resources going to treating COVID patients, these infection control measures reduce the number of available beds and the productivity of staff again. And importantly, high levels of COVID in the community mean that even in a hospital without COVID patients, these measures are still really important to prevent COVID being brought into the hospital. A couple of other direct effects. So we have long COVID, which affects many people according to survey evidence. So long COVID is continuing to have symptoms many weeks after the original infection. And although for some people this seems to be very debilitating, it's likely not to put too much pressure overall on the NHS, in particular because most of it can be treated in primary care by GPs, with, according to the NHS's own guidance, only relatively few people needing specialist rehabilitation. Another really big direct effect is test and trace, but this is actually funded by, despite the name, Department for Health and Social Care, just like the procurement of PPE, so it isn't coming directly out of NHS's budgets. Now I'm going to focus a bit more on these indirect effects, which, as I've said, are actually equally, if not larger, particularly in the medium run. So I've got one slide here on mental health, which is a really important aspect of the pandemic. So this orange line on the left axis shows the number of people in contact with adult mental health services, both before the pandemic, and then you can see that sharp drop off in March and April 2020, and then what's happened since then. So that's a fall of about 10% from the onset of the pandemic. And although this has increased, you can see quite linearly, it's nowhere near, even this many months into the pandemic, nowhere near where it was pre-pandemic. So fewer people, both during the pandemic and still right now, fewer people are receiving mental health care. At the same time, though, demand for mental health care has, if anything, increased. So this chart here, the green lines on the right axis show the percent of adults with moderate to severe depressive symptoms. The dashes are when the ONS surveys have taken place. And you can see pre-pandemic, that was about 10%, and post or during the pandemic, that's risen to just under and then just over 20%. Now, of course, depression is only one area of mental health demand, but it's a large one. And we also think this is symptomatic of a wider issue, that the pandemic has caused more people to have mental health problems or need care, but also fewer people to actually receive care. And that's likely to cause problems for mental health services for the coming years. Another really important area is the care, other forms of care that were missed. And as we're going to see, millions missed both hospital and GP treatment during the pandemic. And care was missed for a number of reasons. So hospitals, for example, shut down non-essential services to free up resources to treat COVID patients. Patients avoided seeking care, maybe because they were scared about catching COVID in hospital, maybe because they wanted to protect the NHS. But also there were some genuine changes in care needs because of lockdown and because of other changes in behavior. Millions lost care, but it's important to emphasize that some groups lost more than others. And IFS have done a lot of work on this. And in some cases that risks those who are already disadvantaged with healthcare inequalities, potentially in some cases lost more care, exacerbating those inequalities. Much of this care is still going to be needed, particularly if we think patients missed care for the first two reasons I gave. Many of them are likely to still need care, but we don't know how many. And we also don't know, given that they've missed care, how much sicker they're going to be now than if they'd been treated originally. And this is therefore a huge and perhaps the biggest challenge for the NHS is to do two things. It's first got to return to delivering routine care because new people are becoming sick every day. But as well as that, it's got to catch up on all the care that was missed during the pandemic. And so returning to kind of pre-pandemic levels will not be enough to achieve both of those objectives. And as I said, millions missed treatment during the pandemic. So to put some kind of numbers on this, in the first 12 months of the pandemic, we estimate there were 3.5 million fewer elective, so pre-planned hospital admissions, 1.6 million fewer non-COVID emergency admissions, and 20.2 million fewer outpatient appointments. Some activity has now bounced back. So for example, the latest data we have is that GP appointments and A&E arrivals are between 2 and 3% above their 2019 levels. But there's actually a little sign of a surge in elective activity. Although it's got better than it was during the first and the second wave, the latest data suggests that admissions from the waiting list are still 12% below 2019 levels. And as I said, they're going to need to be far above 2019 levels to actually catch up. This means, all this missed care means that waiting lists have grown. So this shows the total NHS waiting list in England. In green, we have those waiting less than 18 weeks. In yellow, we have those waiting between 18 and 52 weeks. And in dark green, we have those waiting more than a year. And you can see the total number, it dropped off a little bit at the beginning of the pandemic, but then has risen quite rapidly. by about 1.4 million people. And not only are there more people on the waiting list, you can see the growth in the yellow and particularly the dark green bar. People are waiting on average much longer. But as I've said in the title, this has actually only grown by 1.4 million. And despite that being a large number, it's far fewer than we'd expect to miss care. So we'd have expected maybe another 7 million people to have joined the waiting list during this period who haven't. So as I say, millions have lost care, and most of them never even made it onto the waiting list. And therefore, if and when these patients start to return, waiting lists are likely to rise rapidly, much faster than we've seen so far. And that's behind Sajid Javid's repeated warning about this. And IFS have published some quite detailed analysis on waiting lists. Even in a kind of best case scenario, it's therefore likely going to take years to get waiting lists back to their pre-pandemic levels. And it's worth remembering that pre-pandemic levels were relatively high, particularly compared to, say, the previous decade. The government, through a number of announcements, has now announced about £8 billion for catch-up over the next 3 years. Our best estimate is that this is probably enough to deliver this treatment, but really staffing is the real constraint. Even if hospitals have funding to do the treatment, if they don't have staff to actually do the procedures, it won't get done. Another really important point is actually there's currently very little evidence that the patients who missed care are returning. So despite these millions missing care, we're not yet seeing them come through the system. So for example, GP referrals are still well below their 2019 levels. And just the number of people joining the waiting list are only at their 2019 levels, despite us expecting them to be much higher. One area where we do see patients returning is coming to A&E. So those who've missed care and who are now very sick, some of them are coming to A&E. And this puts pressure on top of onto emergency services, on top of the standard winter pressures that would soon begin. So there are many different ways to measure pressure on emergency services, but this is one of them. So this is the average ambulance response time for what are called category 2 incidents. So these are serious conditions like a suspected heart attack or a stroke. The average time, the target for the average time in the NHS constitution is 18 minutes. And you can see pre-pandemic, we were a little bit above, but quite close to that. But since about April of this year, you can see that the mean waiting time has risen really quite dramatically. And right now, the latest month's data is over 50 minutes, more like 55 minutes average response time for these very serious conditions, which is just a symptom of the kind of pressure that both ambulance services and A&Es and hospitals are under before the kind of full winter pressure has even begun. So to conclude, the NHS is still facing direct pressure from COVID, less than during the 2 peaks, but it's still a very substantial pressure. And these indirect pressures are even larger. So millions of people have missed care during the pandemic, and it will likely, even in a best case scenario, take years to catch that all back up. Our best estimates are that the government probably has provided enough money, though that depends on quite strong assumptions, at least in the short term. And as I say, there are many unknowns here, and crucially, staffing remains a really important constraint. There are other major pressures that have both pre-existed and been exacerbated by COVID, such as staffing and an aging population, and Stephen's presentation is going to cover those in much more detail. So thank you for listening, and I'm going to hand over to Stephen.
Thanks very much for that presentation, Max. I'll just share my slides. As Max said, I'm going to focus not on COVID pressures, rather something we call underlying pressures on healthcare funding in England. So I should have introduced myself. I'm Stephen Rocks. I'm an economist in the Health Foundation's Real Centre. So my first chart here just shows health funding from 2000-2001 up to 2018-19, so prior to COVID. And what you can see is it's rising over this period. Something I find quite remarkable is it actually doubled, so it rose by 103% in less than 2 decades. And that's about 4% growth a year. And this isn't untypical. We tend to find healthcare spend rising over time, about 3.7% a year since the 1950s. And what our projections at the Real Centre show us is that more funding would be needed in 2030-31 to deliver the same rate of care as in 2018-19. And when I say rate of care here, I mean care per head of the population by age, gender, and by morbidity. So why is that? I'm going to concentrate on two reasons in this presentation. So one is increased demand that follows from a growing and aging population with greater morbidity. And the second is rising costs of care over time. So first, thinking about increasing demand. So I'm sure this will be familiar to a lot of people. We have a growing and aging population. By 2030, there's projected to be 3.2 million more people in England, according to the ONS's principal population projections. The actual growth in the total population isn't that great, so 0.5% a year. But the thing that's possibly most significant is that about 90% of this increase is among those aged 60 plus. So you can see that in the charts here. These are population pyramids in broad age groups, 2018 and 2030. And so you can see the main change in the shape there comes in that category of 60 plus. So why is this significant for healthcare spending? Well, healthcare spending generally increases with age. And what I'm showing here are age cost curves for males and females. So this is the average cost at different ages across the lifespan. You can see it's slightly higher at the very start of life, but generally flattens and then increases around about that point that I mentioned, around about the age 60, and rises quickly thereafter. Now, I've said in the title here that healthcare spend increases with age, or does it? And the reason why I flagged that is age might be something of a red herring. So you can think about this, if we had many more 75, 80-year-olds and so on, but they were in good health, that needn't necessarily put pressure on the healthcare budget. So healthcare spend has been found to depend more on two things, on morbidity and proximity to death. I'm going to concentrate a bit on morbidity now. So if we look at past trends, and the chart on the left-hand side here shows for females changes in life expectancy and healthy life expectancy. So it's indexed to 2009 to 11, starts at 100, so if it's above 100, it's rising. And what you can see very clearly here is that life expectancy is above healthy life expectancy. Gains in healthy life expectancy haven't kept pace. So a person born today can expect to spend longer in poor health. And we can see this as well in terms of hospital usage. So the chart on the right-hand side is showing hospital admissions, and I've done this for a particular age group, so it's not a change in the sort of composition by age. So this is females 85 plus, and it's admissions with multiple morbidities. And you can see the rise between 2008-9 to 2018-19, and then our projection is for that to continue to rise thereafter. So we expect to see rises in morbidity, and especially in multimorbidity. So an aging population with greater levels of morbidity, we expect that to lead to that's an increase in demand, and activity will need to increase to meet that. So this shows our projections by service area for different areas of activity. And you can see the highest growth here is in non-elective and elective care, both rising above 2% a year. And you can see particularly for elective care, that's in line with past trends, but that's higher for non-elective care. Interestingly as well, some other categories that were with high rises in activity are community care and social care, both of which saw falls in activity in the past decade. So I'm going to turn now, after rises in demand, to looking at rises in cost of care. So the two things that I'm going to concentrate here on are pay and productivity. So pay is vital for the NHS. The health service is labour intensive. Labour costs account for about 65 to 75% of all costs, depending on the service area that you're looking at. And I can in this chart, we're showing past trend in pay in red, leading up to 2020-21. And what you can say is that real pay, so adjusting for inflation, has been flat or falling over this period. And that's a result of public sector austerity. Going forward, we use the OBR's projection for all economy earnings. So assuming that health pay keeps up with the rest of the economy, and you can see that rises going forward. Now, if pay drives up the cost of care, productivity has the potential to reduce it. So an increase in productivity means you can get more output with the same or less inputs. And looking back, we can see productivity in the purple line has in fact been quite high. There's been high productivity growth. In fact, in this period, it was above the rest of the economy. And going forward in our projections, we use the long-term average of about 0.8% a year. But what you can see going forward is that pay growth would be expected to exceed productivity growth. And if that's the case, then unit costs will rise. And that means that funding growth will rise faster than activity growth. So the table on the right-hand side here is showing the same thing again. So the funding growth now that we'd expect for different service areas. And you can see that funding growth again is high for non-elective and elective care. And this goes somewhat against policy aspirations. So we're seeing this increase in the funding needs for hospital care in particular. I will say that this is only one of the possible scenarios, and the pressures could be different, which I'm just about to discuss. So in particular, the combination of pay and productivity is crucial. I set out our medium-term projections there, but they could obviously differ. So this chart shows just for acute costs, the pay that's needed, the funding that would be needed across time. So in the medium, you have the red line here, but it could be higher or lower depending on the combination of pay and productivity. So if you had low pay and high productivity, pressures could be significantly lower. If on the other hand, you had high pay and low productivity growth, pressures could be significantly higher. So that would add about 7 billion to acute care costs by 2030-31. But what I will say is when we review all the cost pressures, and again, this is across acute care, we find that morbidity emerges as the biggest factor in acute care costs. So you can see in the red bar there is acute care in 2018-19. Population alone adds about 5 billion, so that's just pure population increases in aging. Pay, productivity and prices, they somewhat net each other off there, but chronic conditions adds by far the most significant amount. So what's the implications of this? So in particular, and again, Max flagged this, one of the main implications is the workforce. So our projections suggest that if there are no changes in how care is delivered, up to almost 500,000 more healthcare staff could be needed by 2030-31. I will say then, if I said no changes in care, productivity gains in particular can help alleviate some of this pressure, but we're still likely to need significant workforce growth. And this comes on top of existing recruitment challenges. So for instance, there was a 10.3% vacancy rate in June for registered nurses. There's obviously a lot of talk at the moment about burnout of healthcare staff. So going forward, workforce is going to be one of the main challenges. So in conclusion then, there's significant underlying pressures on the NHS. I hope I've shown that. And the NHS in the budget would need to grow by about 2.8% a year just to keep up with these underlying pressures. So that's before considering the COVID pressures, both direct and indirect, as Max spelled out. Again, somewhat against policy ambitions, much of this pressure is on hospital care. Morbidity and a combination of price and productivity are really crucial in our modelling, and workforce will be a major constraint. And I thought I would just finish just with some ideas of what can be done, at least following from our modelling, as it were, to reduce some of these long-term pressures. There's a range of possible factors here. Some are perhaps more desirable and less desirable. So for instance, increasing thresholds for care is one way to reduce pressure, but that might, so for instance, for hip replacement surgery, but that might not be popular or desirable. Reducing unwarranted care, for instance, so around 15% of emergency admissions are considered unwarranted. Promoting healthy aging, that particularly follows from our modelling, aiming for a compression of morbidity where people spend more of their life in good health. And increasing productivity. So for instance, over the last 20 years, we've seen reductions in length of stay. If that can happen going forward, that would help alleviate some of the pressure, particularly then on the workforce side. So I'm going to finish there and hand over to Sally.
Great. Thank you very much, Stephen. A fascinating presentation. If you could just stop sharing your screen, Stephen, that would be great. So good afternoon, everybody. I'm Sally Warren, the Director of Policy at the King's Fund. I decided I wasn't going to be able to compete with Max and Stephen's slides, so you've just got me to look at whilst I talk to you about social care this afternoon. And obviously, please do keep sending your questions in through Slido, because it would be great to get into a bit of a debate and discussion after our presentations as well. So I was going to talk about adult social care. And really try and answer the question that the Prime Minister said he's going to fix adult social care. Kind of, does the current set of government proposals do that? And I'm going to talk about 3 different aspects of what's needed to help fix social care or get it on the right track. The first is around funding available for the existing system, the current means tested system we have in England. The second is around system reform, so how to improve the quality of the service that people get. And then finally, funding reform, so that long vexed question about how do we share the cost between the individual and the state. So if I take each of those in turn, the first on the existing system. So the spending review last month announced a 3% increase in spending power of local authorities over the course, 3% per year over the course of the spending review period. It's important to say a couple of things about what that 3% is and isn't. That 3% included significant new responsibilities for local government that we'll come on to in a moment. So on a like-for-like basis, this is a 1.8% increase in spending power. Also relies on large increases in council tax to be able to reach that level of spending power. So it assumes 2% increase on council tax each year, and in addition to that 2%, a 1% social care precept each year as well. This is obviously in addition to the health and care levy that we will be paying from April next year as well. So if we think about the spending review being a 1.8% increase in spending power that's based on an increase in council tax, which obviously central government cannot require local government to do, what does that kind of look like in terms of how does it stack up against potential pressures? Well, as Stephen's presentation really helpfully showed, even in just for demand for adult social care, we can expect that to increase at 1.9% a year. So we already have a potential mismatch between the level of spending power available and just the cost of meeting demand. There's then obviously considerable extra cost pressures for social care as well. The most significant ones being around pay. So the social care workforce is one that is predominantly paid at or near the national minimum wage. So announcements around increases to that, whilst really obviously very, very welcome for those staff, getting paid more does increase cost pressures for them. There's a whole set of wider cost pressures, for example, energy costs in care homes that will make a big difference. So in comparison to that 1.8% increase in spending power, I was speaking to a council last week who said they were estimating their cost pressures were a minimum of 6% a year for adult social care. So for the funding to add up in this spending review, you'd have to make a couple of pretty brave assumptions. One is that every single council does utilise the full increased council tax that they'll be allowed to do. Secondly, that council tax rise means that the money goes to the right places across the country. And as I'm sure a lot of you will know, where local authorities are best able to raise money through council tax does not always correlate to where the need is for social care, particularly where means tested social care is needed. And then finally, given pressures in social care are about 6% and growth is only 1.8%, local government would yet again have to prioritise social care, adult social care, at the expense of all other local services. This is something local government has been doing for the last decade, and I think there's got to be serious questions about whether that's still something that's possible for local councils to be able to do, given how much they've had to really strip back some of their other services. So funding for the existing means tested system feels like it's going to remain under quite considerable pressure just to meet minimum cost pressures and to keep up with demand. The second area I talked about was system reform, and this is where, to be honest, we are still waiting for a lot of the detail from government. So we've been promised a white paper on system reform, and that the government have said that will cover improvements to the workforce. It will look at how to better support carers through support, advice, and also respite care. It will look at housing, in particular through the Disabled Facilities Grant and other ways of supporting supported housing. They want to improve information available for people to make decisions, and are introducing a new assurance framework to local authorities and wanting to support improvement more across the system. So all really, really good kind of aims and aspirations, but we haven't yet seen the detail. We're expecting the white paper within the next days, weeks. We've been promised it by the end of the year. Those of you that have followed social care a lot over the last decades will know we quite often get promised white papers and green papers, and they don't always appear, but this we are hoping it will appear. But if I just give a bit of a sense of what's the potential scale of change in the white paper. So as part of the September Build Back Better commitments around social care that were connected to the new health and care levy, government announced £5.4 billion for social care over the next 3 years. It now looks like, now we've seen the tables, around 1.8 billion of that is for system reform in the social care sector. That's 1.8 billion over 3 years. so around about 600 million a year. That's obviously not a huge amount of money for a social care sector that has 18,000 providers, 1.5 million people working on it, nearly 1 million people being supported. So I think some real questions when the white paper does finally arrive about what's the pace and level of ambition and improvement. And to give you a more specific example, of that 1.8 billion, government has said 500 million of that will support the workforce. They've said that that will include looking at improving the provision of training for staff working in the sector, which is really welcome. It will be some measures around well-being as well, but they have explicitly said that will not be about pay in the sector. So we have the potential of a white paper that's trying to transform and improve social care, but doesn't look like it's going to seriously tackle one of the key issues that's a key constraint for the social care sector, which is its workforce shortages. So Stephen talked about some of the vacancy rates in the NHS. In social care, they are just as grave and getting worse. And obviously in social care, particularly for care homes, we've just had the requirement of mandatory vaccinations, which is also meaning that people are leaving the sector. So very high vacancy rates, very high turnover rates. And we now have a sector where people can get paid more in hospitality and in retail than in social care. So we see those problems continuing unless something is done about that. So that's the white paper, which is pretty much a let's wait and see over the next few weeks, but an expectation that it's not going to be radically transformative if that's the only money that's on the table. Finally, we'll come to funding reform and that kind of big question about how we balance the cost between the individual and the state. And this is something that a lot of you would have seen in the news over the last few days, because there's been quite a considerable change in what was understood to be the proposal, and MPs are voting on it today. So let me just recap what the cap is, what the principle behind it is, but then talk about the change that was made last week. So the cap cost model is based on Andrew Dilnot's recommendations from back in 2010. The idea being, when Andrew looked at the issue, he thought it was reasonable for individuals to plan and prepare to make some provision for social care by themselves, but it wasn't reasonable that everybody had the fear of the absolute worst case scenario happening to them, of facing very catastrophic costs. So in the same way that in other fields of our life, we might buy insurance products for our car or our house, that's not available in social care for all sorts of very sensible reasons about what financial services can and can't cost and what risks they can take. So Andrew said that what we should do then is concentrate government spend on the small proportion of us who face very, very high costs. If that risk is taken away, all of us get that peace of mind benefit that we will not face those catastrophic costs. So the government in September confirmed that it was wanting to implement that cap cost model. It set the cap at £86,000. It then also extended the means test threshold, so that support for individuals with lower levels of assets, and it extended the upper threshold from 23,000 to 100,000, so a significant increase, and the lower threshold from 14,000 and a bit of change to 20,000. And what that means is, if you reach a point of having £100,000 in assets or less, you start to get some support from government on a sliding scale. It's set by a taper. I think the closer you get to 20,000, the more support you'll get from government, and then you are always left with your final 20,000. Our perspective at the King's Fund is that is the right principle model to base a kind of new deal, a new partnership between the individual and state, because it concentrates government fund at supporting people with lower level of assets through the means test and providing that protection for everybody against catastrophic costs. So we think it's the right principle, and it's a significant improvement on the current system. But there's going to now be a very big but. So the change that was announced last week was a technical and quite complicated but very important change to how the cap and the means test interact. The simplest way to describe it is, whereas before your personal contribution and the contribution that government makes through the means test, both of those counted towards your cap, government wants to change that, and MPs will be voting on this evening, to say it's only your personal contribution. What that means is individuals of lower and moderate levels of wealth, so somebody with, for example, in Hartlepool with an average house price of £128,000, the vast majority of them, their savings and assets would go to paying for care if they had a long care journey. So they're not really protected from catastrophic costs at all. They still get that slightly more support through the means test. They'll be able to keep £20,000 rather than £14,000. So there's benefit for them from this scheme, but it's mainly through the means test, but they still are faced with that catastrophic cost. And the Prime Minister has said he'd remove that for people and remove that fear of having to sell your house to pay for care. So if I just kind of summarise overall where I would say the PM is on that promise to fix social care, in terms of adequate funding for the existing social care system through the spending review, we do not think that's an adequate level to be able to meet demographic pressures and cost pressures in the system. On transforming the existing system to mean it delivers better quality and better support, we've yet to see the detail through the white paper, but the level of funding available makes us feel like that's going to be quite a low level of ambition white paper. And then finally, on funding reform, it's the right model in terms of a cap cost model, but the detail announced last week does mean it's considerably less beneficial to people of lower and moderate levels of wealth who still now face the very real risk of catastrophic costs from social care. But at that point, I will hand back over to Ben. Thank you.
Wonderful. Thank you very much, Sally. And I just remind everyone that you can go to Slido and ask questions. If there's anything that's popped up there which you'd like to follow up on. Perhaps I might start just in response to something you just said, Sally, on the funding reform aspect of social care. And this question about the cap model being the right one, I guess it's sort of a philosophical question about how we should think about catastrophic care costs. And this current cap is proposed in terms of pounds sterling, and no one should face spending more than a certain number of pounds. But clearly, people this week seem to be getting wound up by the fact that that could still mean a much bigger percentage of someone's assets if they're of modest means, and a much smaller percentage of their assets if they're a millionaire. Now, do you think that thinking about the cap in pounds is the right way to go? Is that when you say things is the right model? Is that what you're thinking, or would a cap in terms of percentage of initial assets? There are obviously different ways you could approach this. I wondered if you had any thoughts.
Yeah, a really good question, Ben. And I think these are, I've worked on the cap on and off for sort of a decade, and you can get to a point where you can design it so it's perfectly more fair, but then it's very, very complicated to explain or very costly to administer. So I think the two most normally raised alternatives is a percentage of assets or time. So if we think about percentage of assets, yes, that would be strictly speaking much more fair. At 65, you determine, or at the start of somebody's care journey, you determine their asset level and then determine what 15% is. That does actually require a very, very considerable amount of assessment of people's financial assets. That at the moment, I think we've got to remember, most people don't pay inheritance tax. Most people don't have that really detailed assessment. Most people needing social care don't even get the social care means tested part. So our view has always been that would create very, very considerable administrative cost burden. You also then, how do you deal with people's assets changing over the course of their later life, or particularly over the course of their care journey? So I think that the principle I understand by saying, of course, catastrophic means a different thing to all of us because we all start with something else, but practically it's more challenging. The other one then is time. And time, is much simpler, 3 years in a care home and you'll get care for free. I think in particular, the one bit that would suggest time isn't quite the right way to do it is recognizing that people have different care journeys. So most people actually don't just go straight into a care home. They will get support in their own home. So how do you count kind of how many years of home care equate to a year of care home? So what the kind of cap cost does by talking about pounds and pence, it really is pounds and pence representing your accumulated care need, and pounds and pence is the easiest way to do it. But it's kind of in that trying to recognise the fact that it's 3 years of needing a few hours of home care is a very different financial burden on you than 3 years of being in a care home. So it is really tricky. None of them are completely perfect, and you have to do that balance of how you can administer it, but also how you can explain it, and then what does that mean about how perfectly fair is it?
Yeah, and I think it's also important to bear in mind that, as you said, no system's perfect, but they're almost all an improvement on where we are now. So
exactly.
Even don't let the perfect be the enemy of the good, I guess.
Absolutely agree. And we've been waiting 20 years for a better system. So let's jump to one now.
Yeah. And I think you make a really important point there as well about the sort of the admin burden for local authorities, or who are going to actually have to. There's a big gap between announcing a policy and actually having it work in the real world, and councils will play a crucial role there. And there's also a question popped up on the slide, which I think I'd like to, if it broaden slightly. It's a question from Jess at Bernardo's asking about how most of when we talk about this, it's about adults. And in particular in social care, we talk about as it is almost like a problem that exclusively affects the elderly. But of course, we know about half of all social care spending goes on younger adults. And Jess also mentions explicitly children. And I know children's social care is a whole different field. But do we need to make sure we don't lose those important areas when we're thinking about the issues facing the elderly?
Yeah, a great question, really good question, Jess. So absolutely, children's social services also under a lot of pressure. We don't cover children's social care, so we don't have the detailed analysis from the King's Fund. But I suppose where I kind of think about social care and the kind of different age groups is most, but not all, working age adults with disabilities will receive some form of means tested support. So the most important area of reform for that group is the system reform stuff. It's the how are we going to improve the quality, the personalisation, where's the workforce that's going to deliver good quality care, and to make sure that there's enough funding for local authorities to meet the needs that are presented to them. So I think that's really important. The reason why we tend to talk an awful lot about how older people pay for care is because at the moment they are paying for it themselves, whereas obviously for working age adults, it's already means tested support. For children's services, it's provided by and paid for by the government. So you end up with that kind of big debate about, is it reasonable for an individual to pay for their own care? Should it be a more collective risk pooling like the NHS is? What's the appropriate transfer from private spending of wealthier people because they have a care need to a collective risk pool? So that's why you tend to have the funding conversation be about older people, but absolutely the wider system improvement needs to be really important. And there's a major issue with transition from children's social services to adult social services as well, to make sure that really works for children and they can live the lives they want to as young adults in our communities.
Absolutely. Stephen, perhaps I might come to you now. There's a question about, well, two really. First of all, you have a nice chart showing sort of underlying comorbidities and the number of chronic conditions with which people are living rising over time. And this also occurred to me as well. So that's, I believe, resourced from looking at hospital data and looking at those records of those people. And there's a question here asking whether that's because maybe underlying habits like diet or obesity might have changed. I mean, those are genuine increases we're seeing, or is it just better detection or changes in data recording that might be driving that?
Thanks, Ben. Yep. So there's reason to believe that over a longer time span, recording would have improved. So for instance, in general practice, GPs are partly remunerated on their performance against something called the Quality Outcomes Framework, the QOF, which involves some measurements of patients and so on. So there's reason to believe that would have happened. But I think most of that would be further back. And so from at least 2009, we would believe that is a real increase, especially in HES recording, yeah, and also in general practice as well. I think there are some changes, obviously, in risk factors. So obesity going up, which we hear a lot about. But a really interesting reason, which I think some research that the Health Foundation funded found, is that some of the people that might be surviving, so increased survivorship, so as a result of better treatment in the NHS, people living longer, some of those that are surviving might be people that would otherwise have developed long-term conditions later in life. So increased survivorship, that might actually be a sort of good story, as it were, and is another contributing factor.
Thank you very much. There's a question then about sort of related about the impact of sort of it's quite a dark question, I suppose, but the impact of higher mortality during the pandemic and what that might mean for care demand. And I guess probably Max and Stephen will ask you for your thoughts. Perhaps Stephen first, then Max.
Sure, because Max, I think you may have some of the detail on this, but we did look at taking some of the excess deaths and stripping that out of our population projections. So I mean, again, yeah, you're right, Ben. It's a very sort of morbid factor, as it were. That's but it could be that some of those older groups are slightly smaller as a result of excess deaths during the pandemic. But we didn't find it was actually that sizable an impact in terms of funding. And I think because earlier on in the pandemic, there was a kind of logic that some of the people that were dying are people that would have died anyway or would have multiple conditions and so on. And that isn't necessarily the case. Obviously, the age band was a bit more spread out than maybe was expected at a certain point. Basically, we didn't find it was a very big factor, but it would be a factor and it would slightly reduce some of the demand, for instance, for non-elective and elective care.
And Max, I know for a fact you've looked at this in the past, so perhaps you could talk for a few seconds about that.
Yeah, so we looked at this more from a kind of short run perspective of just over the next couple of years, how much could the mortality save? As you say, it's a morbid question, but it's a valid question, and OBR have, for example, looked at savings to public pensions, again, from this mortality. It's quite hard to estimate accurately. We, I think, came up with a figure that it might save the NHS 200 million a year for the next couple of years. So that, as Stephen says, is in this grand scheme of things, not that much money. It's quite hard because, as Stephen says, that was based on age and mortality. We might expect these people to be somewhat sicker than average, but that kind of has two effects. It means in the short run, we might be saving more because they might have been heavy users of healthcare, but they might have also already had shorter life expectancies. And so maybe that kind of concentrates the benefits in the shorter run. But it's a really kind of complex how you'd model that. But yeah, I agree with Stephen that it will have an effect, but not a very large effect.
Great. There's a question, again, I think this is probably one for you, Stephen, about thinking about, so I've thought this as well, but NHS productivity, trying to reduce it to just a single number to capture all sorts of different inputs. And are we measuring it based on the output the NHS produces? How does quality enter it? It's quite an abstract concept to sort of get your head around. So the question is specific about how you measure it, but it's clear key input into your model as you make clear. And how might we achieve a world where those productivity numbers are better?
Yep. So the ONS and the Office for National Statistics, and also the Academic Health Economics Unit up in York, they both measure productivity in the English NHS. And you do it, as you say, there's a range of different activities across the NHS, ranging from primary care consultation through to an emergency admission and procedure and so on. So it's cost-weighted output. So you weight it by the unit costs of those different activities to come up with a series for output. And likewise for inputs, you have a range of inputs, mainly staff, as I mentioned, and it's staff by different bands and so on, but also drugs costs as well. So that's weighted too. And you compare those two measures. So it's input compared to output across time. I think in terms of, sorry, I should say something else about productivity there insofar as I think productivity is a slightly distinct factor compared to sort of efficiency, for instance. So one of the interesting things I mentioned there, it's output, so it's cost weighted. So if you're able to avoid an unnecessary attendance, for example, that might be an efficiency saving, but it wouldn't really show up in productivity figures because that activity no longer took place. It would no longer feature in the cost weighted output. So I think it's quite an interesting thing there about the difference between productivity and efficiency. Yeah, and in terms of how to improve productivity, I think we have seen over the last 2 decades, in particular for elective care, we've seen falls in length of stay and also an increase in the proportion of elective treatments that have been delivered as day cases. So we're seeing shorter stays in hospital, and what that means in effect is that you can do more with your existing bed base, for instance. So you can get more activity, get through more activity with the same number of inputs. And that's been a big driver of productivity improvements. Another would be task shifting. So for example, in primary care, we've seen sort of specialist nurses taking on more tasks that might otherwise have been delivered by GPs. And that's probably shifting down in terms of the cost of the person delivering that. So that would again show up as a productivity improvement. I would stress, I mean, productivity has been high in the NHS in the last 10 years. So it's actually been a very successful period for NHS productivity. And going forward, maybe maintaining some of those changes would be helpful, so reducing length of stay. And obviously there's a prospect of technology doing more, and the move to, say, remote consultations potentially contributing to productivity, although it's not wholly clear how that would happen. Because, for instance, a remote consultation might save time on the part of the patient, but if you have the GP still spending the same amount of time, for instance, delivering a remote primary care consultation, that wouldn't necessarily constitute a saving. But you might have, for instance, lower did not attend rates, DNA rates, and that could be an improvement.
So it seems to me that sort of relates in part to some of the questions that are popping up here on in the slide. There's obviously a clear focus on workforce, and it's true for health and for social care. And some of the things you talked about, Sally, about pay in the care sector, sometimes struggling to keep pace with that in retail or hospitality, or you hear sometimes stories about workers going to work in Amazon warehouse because the pay is much better. And I guess my immediate thought was to look at this immediately through the lens of economics, and there's the very famous idea called Baumol's cost disease about where very labor-intensive industries struggle to keep pace productivity with more capital-intensive industries, but the pay has to rise to match. And it seems that healthcare might suffer from that. And I guess the question is, how do we go on? There's a question here asking about how we might create the care workforce of the future, and how when there are other alternatives available for people, how can we make sure that we have enough people working in health and care to deliver these levels of activity? And pay is clearly one factor. There's also a question for the role of immigration. There's a question here specifically about the vaccine mandate and what that might do to staffing pressure. So I wondered if perhaps you first, Sally, quite a broad spanning question, I realise, but some thoughts perhaps on the challenges we're facing and what might help address them.
Great, thanks a lot, Ben. Yeah, I'll try not to do a 45-minute answer to those 10 questions. So absolutely critical challenge around the workforce, and I'll particularly focus on social care because I'm sure others will come in on the NHS. So there are some particularly unique challenges for social care in comparison to the NHS. So, for example, we have 18,000 employers in England in social care with all of their different terms and conditions, as opposed to kind of one set of terms and conditions in the NHS. There's a much clearer career pipeline and pathway in the NHS, even if you're moving between hospital trusts or between trusts and GPs, it's a much more established pathway, whereas in social care it quite often isn't, and quite often you're having to repeat all of your training every time. So I think there's a whole host of things that we need to do. One is being, yes, pay is an issue, and I'd say I'm not going to debate economic theory with economists because I'm not one, but I would say there's one particular issue for social care, which is the reason it can't keep up with pay from other sectors is that government isn't paying enough for care. So if you look at how much government's been paying its fee rates for the last decade, it hasn't been keeping up. So that means all providers can afford to do is just the bottom, bring everybody up to the new national minimum. They can't do anything else. So we've done some analysis at the King's Fund that shows the pay differential between a brand new entry into social care and somebody who's been working for 5 years is 6 pence an hour. If that's all the differential, then really you risk losing your more experienced people to other sectors. So pay is a really important part. There's a really important thing for me about career progression and how we can make it that you can make a career and move throughout your career and your lifetime. That requires providers to be thinking more collaboratively about what's the skills passport, what the values and skills we want, how can we encourage people to move around rather than kind of it feeling more challenging to jump a whole set of things around well-being, how we can better support staff. So pay is important, but it's not the only thing. I would say on immigration and social care, one slightly tricky thing is I think immigration is part of the solution for social care, but unlike with the NHS where people actively come from another country to work in the NHS, what we've tended to find with social care, it was immigrants who had arrived in the UK who then for various reasons chose to work in social care, but it wasn't the primary reason they moved here in the first place. So I think just changing the visa system for social care isn't likely to be as simple as an answer as it might be for some of our NHS workforce shortages. But I think at that point I answered enough of those 10 workforce questions to throw the ball to either Stephen or Max, if that's okay.
I did just have a couple of thoughts that I thought I'd come in on. So I mean, I think on the NHS side, thinking about staffing shortages, it's likely to be a combination of training more domestic workers, foreign recruitment, and also retention. So again, keeping workers in the workforce, and that echoes some of the points that Sally was raising about the potential of people leaving and so on. I thought just on the BOMO point more generally, because it is interesting to reflect that in the last decade, again, productivity in the health service unusually was higher than the rest of the economy. But the reason in part for that was that you had low economic growth, for instance. And it's interesting because that meant that you have less pressure on the healthcare budget, but you also have lower economic growth, lower growth in government revenues and so on. So it kind of gives with one hand and takes with another. That's So in some respects, we do want an economy that's growing. We do want high productivity growth in the rest of the economy, and that would drive up wages, which is one cost in the NHS, but would also mean that the economy is expanding and tax revenues are going up. So I think it's quite a complicated issue.
I think that's right, but isn't what part of the reason why NHS productivity since 2010 has on paper performed well is because the budget was squeezed, pay was squeezed, input costs are held down whilst output was still growing, so that it's not bound to have good looking productivity numbers.
It shouldn't be a pure price effect. So I mean, again, because it's chain weighted and so on, it shouldn't just be the reduction in pay. But I think where you've had, again, substitution of task shifting, as it were, so where perhaps a lower band staff member is performing those tasks, and that might have that certainly some of that will have contributed in the last 10 years. Yep, I agree. Not all of the gains in productivity have been, how do you say, probably from the best source. And perhaps some of the what looked like lower productivity in the 2000s when we had very high growth in healthcare spending. And we didn't see the same sort of productivity rates, but we did have an expansion of the workforce. And in some ways that probably put in place the sort of seeds of when you were able to sort of reap some of those gains in the 2010s. So it's perhaps a little bit cyclical as well in terms of how you can achieve productivity gains.
Yeah, sure. And the point you make about the skill mix changing is important. And perhaps, Max, I could bring you in here. So clearly there's lots of scary things floating around, and COVID has had enormous impacts on huge parts of the health and care sector. But one thing people have talked about is that there might be, permanent lessons. The NHS itself has said there might be permanent benefits that we can lock in, and some of that might be to do with around skill mix and experimentation that we've had to do, and perhaps we never would have done otherwise. And so if you're taking a glass half full approach, what might some of the benefits or lessons we can learn from the NHS be from the pandemic?
Yeah, that's a really good question, because obviously the pandemic has been terrible for the health service, given that it's a pandemic. But yeah, there are some potential silver linings. And I think, as you say, even in kind of April 2020, so just a month in the pandemic, NHS England were kind of pushing that some of these big disruptions and changes, if they were beneficial, could kind of be locked in their terms. So there are many different potential benefits. Stephen already mentioned one, for example, which is remote outpatient or remote GP appointments. Again, this is unlikely to potentially might not save much clinician time, but one of the potential big benefits is reduced not arrivals, which, so we've modeled that could save actually quite a lot of money. It's amazing how much outpatients has been shifted. As we said earlier, there have been 20 million fewer outpatient appointments, but actually there would have been probably double that. It's just that many have been moved to remote and telephone. And so if that kind of maintains, that could be a potential benefit. Of course, it would have to be implemented well. And I think Health Foundation have done some work on that. There are many other potential benefits, again, and how different staff doing different things. Again, coming back to this point about staff mix, the pandemic meant that people were doing what they wouldn't normally be doing in a hospital. And maybe some of those benefits, some of those things were beneficial and again, could be carried forward. So yeah, I think it's really hard to know actually right now, but there are potential benefits here.
If I could just quickly jump in on this, Ben, to link some of those benefits to the current legislation that's going through the House. One of the things that we saw a huge amount over the pandemic was real collaboration and joint working amongst different hospitals. So sharing of staff across different sites, shifting of pathways to mean that one hospital was sort of what we called hot, the other was cold. And I think for ages we talked about the potential benefits of integration, but a lot of people hadn't touched it and smelt it. And actually doing that under the pressure of the pandemic meant that they started to see that they could work differently. And with organisations they had before been meant to be competing against. So actually they finally were not just collaborating in theory, they were doing it. They were thinking about it on Monday and they were doing it on Tuesday. That's sort of how quickly it was happening. So quite a lot that's in the new health and care bill about integrated care systems and integrated care boards, that's about trying to lock in that different way of working that says we're not all competing units, we're actually trying to think how to best use our resources in a different way. And some of that's also being across the NHS and social care boundary, with NHS leaders thinking the quickest way for us to increase our capacity is to get more social care workers into the sector. Then that means more people can be supported at home, rather than thinking the answer to the NHS's problems is more NHS staff. So some really creative thinking as well.
Well, it's great to have some positive news for once. There's also a question which relates to the top one on Slido, actually, which is not just about sharing hospitals and workforce between different NHS trusts, but also one thing that happens is the sharing of workforce between the public and private sectors. And we know, for example, lots of NHS doctors do private sector work as well. And there's a question here about what's the role of the private sector effectively in trying to deal with the waiting list backlog. And then perhaps I'll say a few words, and if anyone wants to join in, please do. I guess clearly the private sector, even pre-COVID, was playing a role in performing lots of routine elective surgeries. I know that work from some of my colleagues here at the IFS has shown that that boosted public sector capacity, it allowed the public sector to do more hip replacements, for example, than it otherwise would have been able to. And there's no reason to think that there isn't a role for the private sector in dealing with the backlog. I guess my one concern I have is that, well, first of all, it's not obvious that always more private sector activity increases the net amount of care if the doctors doing the private sector activity are doing less NHS work as a result. So you've got to clearly take all of this in the round. And then secondly, there's lots of, we've seen, I think the data on this is fairly poor, but anecdotally we know there's been a big increase in demand for out-of-pocket payments for private care. So people going, sick of the NHS waiting list, I'll go and pay for my own like joint operation, whatever it happens to be. And if that's happening, private sector hospitals may find that to be more lucrative than taking NHS contracts. So I'm sure the private sector will play a role, but precisely how big a role and, you know, that all remains to be seen. I don't know if anyone else has any other thoughts on that. Sally, you've gone off mute, go on.
I would just to reiterate the point about kind of how much of that is genuine additional capacity. So a lot of the staff who make up the private sector are NHS staff. So, you know, they're already exhausted through what they've done over the last 18 months. I think the idea that they're both going to be able to maintain current levels of NHS activity and do more in the private sector is, I don't think, very reasonable. Plus, you add in all of the pension and tax complications for consultants, and they're not particularly incentivized to do extra work at the moment. So I think, yeah, it's easy to think about, kind of imagine these are an entirely different, separate system with all of their staff and all of their facilities. The facilities are there, but the staff is a much more shared resource, and I think most people would understand.
Any final thoughts, Stephen or Max? We think about almost time for us to wrap up.
I would just mention on that as well, there might be a mismatch between the supply and demand in the sense that there's a lot of private sector capacity, for instance, in London. That might not be where the patients who miss care are. Likewise, I think the private sector does a lot of some procedures, but not all procedures. So again, that might not match up. But otherwise, echo both your own points and Sally's.
Okay. I think we're not going to have time to get to every single question on Slido, so I'm sorry if we didn't get round to yours. Clearly, we should have booked in 2 hours rather than just the one. But thank you very much, everyone, for joining. Thank you ever so much to Sally, Stephen, and Max. And I hope you all have a wonderful afternoon. Bye.
Thanks, everyone.